Good morning, everyone. I'm Dr. Priyanka, lecturer in prosthodontics, and today I'm going to take the second prosthodontic lecture, which is diagnosis and treatment planning for partially edentulous patient. So before earlier lecture was about completely edentulous patient. I hope you remember, and we took in detail of the case history. So now we'll take up the systemic history in detail, and we will talk about the partially edentulous classifications and okay, so coming to the learning objectives, the learning outcome. So at the end of the lecture, you should be able to understand the importance of patient interview and history taking. So we did this in detail the last lecture. Infer the importance of diagnosis in planning treatment for partially edentulous patients. Discuss the steps in oral examination and diagnostic findings. Differentiate patient needs and make decisions over selection of prosthesis. So coming to removable prosthodontics, okay. Um, okay, all right. So this is an RPD and an RPD, basically a CPD, that is a cast partial denture, which consists of a metal denture. Okay, so it comes under removable prosthodontics, guys. Okay, so removable prosthodontics is defined as a replacement of missing teeth and supporting tissues with the processes designed to be removed by the wearers. Okay, so it can be removed by the wearers and it okay, coming to removable prosthodontics, which consists of partial and complete. We have covered complete in the last lecture. We are talking about a partial denture now, which consists of an extracoronal and intracoronal portion. So coming to the basic terminologies which is used in an RPD, that is an appliance. Appliance is a device worn by a patient in the course of treatment. Okay. It can be a space maintainer, an appliance, a surgical appliance. Abutment is a tooth, a portion of a tooth or a portion of a dental implant that serves to support and retain the prosthesis. Okay. Retainer is a fixation device or any form of attachment applied directly to an abutment tooth and used for fixation of a prosthesis. Okay, so this is known as a retainer. Tooth supported RPD. Tooth tissue supported RPD also exists. So tooth supported RPD is a partial denture that receives support from the natural teeth at each end of the edentulous spaces. Tooth tissue RPDs, the denture base that extend anteriorly, posteriorly, and supported by teeth at one end and tissue on the other end, like the distal extension. Coming to temporary removable partial dentures, which is used in patients where tissue changes are expected, and then the permanent process will be placed later. Interim dentures are partial dentures which act as a temporary dentures for a short period of time. So when you are having like a patient which wants to go for an implant and the extraction socket is not ready, you can give like an immediate denture, so that will serve the purpose of an interim denture. Okay, transitional denture may be worn when loss of additional teeth is inevitable and but like after immediate extraction is not advisable or desired, so you can wear it in that transition phase. Okay, treatment denture used as a treatment material. So basically like ill-fitting dentures, sometimes they have soft tissue issues, soreness and all. Sometimes we give tissue liners, soft tissue liners, so and then we'll have to fabricate again and make it permanent by relining, rebasing the denture. So those dentures can be called as treatment dentures. So one other definition, centric relation, which is basically more used in a complete denture patient. So it is the most posterior relation of the mandible to the maxilla at established vertical dimension from which the lateral movements could be made. Okay, so guys, okay, coming to the intracoronal partial denture, any prefabricated attachment for supportive retention which is placed in the denture prosthesis. Okay, so this is like I told you, extra and intracoronal. So there's a male and female component which can be attached to the denture. So yes, that also can be done. So it can be like precision attachment. Example is a precision attachment. Okay, so indications of RPD generally, so it's the length of the edentulous span that contraindicates the use of FPD. There are in relation to patient's age, no abutment tooth posterior to the edentulous space. Yes, this is very important. So if there it if there is an abutment teeth, you can do like an FPD, you can do like a 3-unit bridge, okay? But if it's not there, you have to do an RPD. Reduce periodontal support for remaining teeth. So FPD cannot be indicated here. Need a cross arch stabilization, then excessive bone loss of residual ridge, okay? Then there are physical problems. A patient is not willing to really adapt well to the prosthesis, okay? Aesthetics, if they want to restore that the aesthetics immediately, it can be done. Need to replace it immediately after extraction, yes. So a fixed prosthesis cannot be indicated. And then the patient desires, if the patient wants. Contraindications, a lack of suitable teeth in the arch to support and stabilize and retain. So in our department, we see that we tell the patients to get it extracted if it's not stable and proper. So you need to extract it. Okay. So there has to be proper supporting teeth, because we'll also have to give clasp attachment, and the processes will seat there, and the patient will remove and put the prosthesis back, so it should not loosen the teeth remaining. Okay, rampant caries or severe periodontal condition is not indicated in such cases. A lack of patient acceptance for aesthetic reasons, and poor oral hygiene. Okay, so coming to the Kennedy's classification, which we basically use always. Okay, it's a universal classification to identify the edentulous spaces. So that's how. So bilateral posterior edentulous spaces next to the remaining anteriors and few posteriors is class 1. Unilateral edentulous area located to posterior of the remaining natural teeth is known as class 2. Class 3 is unilateral edentulous area with natural teeth on both the side, anterior and posterior. That's class 3. Class 4 is bilateral edentulous area located anterior to the remaining natural teeth. Okay, so this is an anterior location. Okay, so class 1 classification should follow rather than precede the extraction. If the third molar is missing and not to be replaced, should not be considered. If the third molar is present and is to be used as an abutment, it is to be considered in the classification. If the second molar is missing and it is not to be replaced, it should not be considered. Okay. The most posterior edentulous area always determines the classification. Okay, edentulous area other than those determining the classification are referred to modification spaces. Okay, so you have to know those. That's why like I told you, class 1 modification 1. So that's a very common way of referring to the classification by using the Applegate rules. Okay, rule 7, the extent of the modification is not considered, only the number of the additional edentulous spaces. Okay, so that's what I was talking about, only the number of edentulous spaces. That 3 teeth are missing one side, 3 teeth are missing the other side, there are 2 edentulous spaces. It doesn't mean there are 6 edentulous spaces. Okay, so it will be like a class 2 modification 2 or 1 or whatever. Okay, so rule 8, there is no modification area in class 4 arches. Any edentulous area lying posterior to the single bilateral area determines the classification. Okay, all right, just know them, guys. Steps in fabrication of an RPD. Sorry about that. Yeah. Yeah. So that is just RPD written here. So coming to prosthetic examination, then you take a primary impression. You can have study models if you want. If you don't have study models, you can use a primary cast as a study model. Mouth preparation is required to design. If you're doing a CPD case, that's a cast partial denture case, designing a framework. After doing the designing, the receipt preparation, everything, you take a final impression, guys. Okay, then the framework trial is done, adjustment is done, then you do an occlusal rim on top, you do a bite registration. Okay, then final impression of the edentulous ridges, fabrication of the acrylic denture base, occlusal registration. Yeah, okay, and then after occlusal registration, you do a denture tooth selection, and then you do a trine, and then deliver the RPD, do the initial adjustments, and do a follow-up, guys. Okay, this is just the basic steps of fabricating. And yes, things modify and get complicated according to the cases, guys. So coming to the general components of RPD, that is the major connector, minor connector, rest, the indirect retainer, denture base, and replacement teeth. Okay. Okay, so 7 components, guys. Always remember denture base. This is the replacement teeth. Okay, this is the direct retainer, guys. This is the um, minor connector, the indirect retainer, major connector, rest. I don't know you'll be able to appreciate or not. Okay, so these rest we put the inside the rest on the occlusal surface of the teeth. Okay, depending on the design and depending on which rest we want to put. So we'll talk about it later. Coming to major connector, so it's defined as the part of removable partial denture which connects the components on one side of the arch, the components on the opposite side. Okay, so that's the major portion. The minor portion just links between the major connector and the other units of the prosthesis. Okay, the other units class rest, indirect retainer, and denture bases. Rest and rest seats are components of RPD that serve primarily to transfer forces occurring against the prosthesis down the long axis. Okay, so these make the forces stabilize. The rest seat is prepared on the surface of the tooth. Okay, and according to the rest seat principles. A direct retainer, the component that engages an abutment tooth and is so doing resisting the dislodging forces, guys. Okay, the indirect retainer, a component of RPD which assist the direct retainer in preventing the displacement of distal extension bases by functioning through lever action on the opposite side of the fulcrum line. So there's something known as fulcrum line. We'll get into detail, guys, in designing, then you'll be able to understand the fulcrum line. Denture bases are the bases which rest upon the basal seat and where the teeth sits on. Okay. Okay. So coming to the appointments, guys. So it's a very famous saying which says we should meet the mind of the patient before we meet the mouth of the patient. So we have to understand what type of patient is there and what is the requirement of the patient. Okay, that should be done basically in the first appointment. Okay, so coming to the definition of diagnosis. So the determination of nature of disease diagnosis is the determination of the nature of diseased condition by careful investigation of its symptoms and history. So you have to know the symptoms, you have to know the history, you have to know everything in detail, guys. Okay, so coming to the psychological classification of the patient. Okay, physiological and exacting, indifferent, and hysterical. So this is the most difficult patient, this is the most ideal patient. Okay, so sequence of events, how do we do it? We take a medical history, we take a subjective history, diagnostic consideration are used, analysis of the data collected, the clinical diagnosis, and the treatment plan evaluated. Okay, coming to the medical history, so many of the removable prosthodontic patients we treat are geriatric, so they have compromised health and it has an impact on the treatment. So any of the history has to be reviewed, the medication, hospitalization, and treatment. So we know how long to appoint the patient, when do we call the patient, what medication is supposed to be taken, how long can we make the patient sit, can the patient walk, can the patient sit upright, and everything. Okay, so coming to the cardiovascular diseases, so it requires the medical consultation. Okay, so it's acute MI, that's a myocardial infarction, angina pectoralis, any congenital heart diseases, arrhythmias, hypertension, if they are taking BP medications or not. Okay, so you in these patients you're supposed to monitor the BP once they come to the clinic. Okay, diabetes, so they have a decreased resistance to infection, so they get infection very fast, the healing is slow, so we have to take that into account. Or when are they taking their medications, have they ate something and came or not, so everything has to be managed properly. Patient often display reduced salivary input, so it makes our dentures and processes difficult to fit, but in few patients, not in all. Arthritis, yes, seen commonly in the old patients, so can be, it also can be like a TMJ thing, guys, so it may produce changes during occlusion, very rare in the TMJ, and it can be produced in the TMJ, but however it is quite rare in the TMJ. Okay, if there it is there, it would be like a secondary site, not a primary site. Okay, so it's more on the joints, guys. Okay, so you have to know where to seat the patient, how to manage the patient. Parkinson's disease, so oral hygiene and handling of the dentures will be impaired. There will be difficult impressions due to excessive quantity of saliva. Okay, so that is one thing you have to manage. Paget's disease, patient may present enlarged tuberosities, which is quite rare, but then you have impressions how to, you have techniques how to manage that, guys. And okay, so there's acromegaly, so that is the enlargement of the mandible. Okay, so this is a very frequent examination to evaluate the fit and function of the removal removal prosthesis. So it's just an examination which is frequent, but it's not a frequent condition, guys. Okay. Epilepsies, there's a removable dentures may be contraindicated if they are small, and seizures are frequent and severe, so choking can happen, so we have to be very careful. If patients take phenytoin, the common drug, make sure that the RPD does not irritate the gingival tissue. So you have to see to that they do not choke through the processes, and it doesn't hurt them, because in epilepsy, if they have seizures, they'll tend to bite things badly, right? So it might hurt severe them. Okay. Okay, so coming to this condition, um, pemphigus vulgaris, common condition, so it will create oral discomfort and dryness. So we can establish a smooth and polished border to reduce soft tissue harm. Greater follow-up is anticipated, obviously. Okay, treatment for cancers, yes. So you can see like an oral cancer, so xerostomia, irritation, bacterial fungal infections are the oral complications. 40% of the patient who have cancers outside the mouth have repercussions inside the mouth. Yeah, so the mouth can tell you a lot about the systemic status of a body, and we have to be careful in that, guys. Okay, so if there is cancer, you have to get the cancer treated first, and then we have to do the management according to the patient. Okay, transmissible diseases, so hepatitis, TB, tuberculosis, influenza, HIV. We have to be careful. Make sure impressions are disinfected. Okay. So we do disinfect our impressions every time we take it. Okay. Effects of drugs on treatment. So anticoagulants have a post-surgical bleeding. Antihypertensive. It has an like a xerostomia basically in diuretic patients. This is more important for us. Endocrine therapy also has xerostomia, so we have to manage this well, guys, and we have to know what drugs they're taking and what conditions they're under. Okay. Coming to the subjective history, expectations of treatment. So get the chief complaint correct. Okay, so the dental history, you have to exactly know how he lost the teeth, and when did he lose the teeth, and how long has it been, because it will tell us about many things. Okay, gather information about existing denture if they are RPD wearers, in this case as we are talking about partially edentulous patients, and if they have old x-rays, they can show it to you. Okay. Subjective history is more about habits. So, do they have a habit of bruxism or clenching? And we have to create a process according to that. Do they have tongue thrusting habit? We have to modify processes according to that. Or even if they are, in few cases, they are not even indicated. So, we can explain that to the patient. Okay. Coming to the diet. So, there are frequent uses of mint, soft drinks, sugar containing products. So, you just need to know how the patient is eating and what the patient is eating, because yes, these are important in partial and edentulous patients, because we are supposed to replace them with artificial teeth. Okay, coming to the diagnostic consideration, coming to the dentition and supporting apparatus. So I will be talking about dentition and supporting apparatus. Apparatus is the intra-arch relationship, intra-arch, DMJ muscles. Okay, coming to the initial examination. So you have to evaluate the oral hygiene, evaluate any caries susceptibility, any contours or potential abutments. Okay, so if the abutment is tilted, or it has secondary caries, or is it already crowned, if there is already an FPD on top, and how are we going to replace the rest? So or how are we going to give a clasp on a crown teeth in case of RPD? So we have to know, you have to know the occlusion. Is it a deep bite? Is it an open bite? Is it a class 1, class 2, class 3? Okay, possible extractions if there's something mobile, something carious. Okay, and then if there is any mobility, or if any extractions are required, or if any extraction socket present, or if there are any root stump present. Coming to diagnostic tools, so Here you have to take a radiographic evaluation for abutments, especially do pulp testing if required for abutments, diagnostic impression, diagnostic casts or study casts which can be taken. So usually, yes, we do take radiographs if required, and yes, we do study models if required. Okay, so that's the diagnostic tools. Coming to the radiographic assessment, so radiographic evaluation of the prosthetic abutment should include all the following: the abnormalities, the pathologies, crown root ratios, guys, bone levels, where are the bone levels, any pulpal consideration which has to be taken in case of tooth alignment and root proximity. So, is it coming too much proximal to the root surface or not? So, everything has to be assessed. Any pathologies, okay? The crown root ratio is important, okay? So, bone levels, everything has to be seen. This is an OPG, guys. Everything has to be seen, properly evaluated, and then you can proceed with the fabrication of the process. And then remember, treatment and the department comes at the end. First, all the treatments has to be done by the other departments, and then they will. Coming to the periodontal consideration, the bone density is important, crown root ratio again, probing depth, attached gingival furcation, oral hygiene. So everything you learn in detail in periodontics. So any of these teeth, especially in the abutment teeth which are present, will give you a stability of the process or will lead to failure of the processes. Everything needs to be evaluated in the single teeth. Okay, so the root, the crown, the attached gingiva, the furcation, the hygiene, the gingiva, everything, and the bone density. Okay, tooth mobility, trauma from occlusion is a phenomenon which has to be evaluated. Inflammation of the periodontium, loss of bone. So you can see, like, we can use an abutment here. Maybe you cannot, use this abutment. Okay, but you can see that for overdenture, it's still we can use it. Okay, this one can be used. All right. Mm, you can use this in a partial denture abutment, but again, I would not prefer that, guys, because later this will lead to mobility, and there we have to give a clasp at one place. You cannot give a clasp on the root, guys. Okay, so it's important. Residual ridges, yes. Tissue attachments, high or low, has to be seen. Oral mucosal condition, palatal wall shape, ridge height. Okay, anatomical structure, the frenals, the tongue, the mucosa, how is it, hard tissue abnormality, soft tissue abnormality. So if teeth are present, any abnormality, then that space for mandibular major connector, is it even there to design it? If there's a tora, what are we supposed to do? So those things have to be evaluated too. So evaluation can also be done on mounted diagnostic cast. Okay, so you can see that the interart space is less or not there. Okay, occlusal plane is there, not there, irregular occlusal planes. Okay, guys, everything needs to be evaluated properly, and then what are you supposed to do? Okay, do we need to increase the vertical dimension or not? So that for that you need to evaluate the interarch occlusal relationship. Okay, evaluation of mounted diagnostic cast. So relation of the arches has to be done. Tipped or malpose teeth has to be seen. Occlusion has to be evaluated, guys. Okay. Okay, finally, diagnostic wax up can be done. So we can just like put teeth and see wax up, and we can consult and we can do discussions and we can develop a treatment plan, guys. Okay, so that is known as a diagnostic wax up. Okay, coming to the analysis of data, it can be done through the interpretation of radiographs. It can be analyzed through articulated diagnostic casts. Sorry. Previous prosthodontic histories can be taken, extra and intraoral examination can be done, and all the history can be correlated. Okay. Okay, so coming to the last few slides, this is developing finally a sequence treatment plan, dear. Okay, guys, treatment plan. So phase one would be evaluation if immediate treatment is required. So any immediate treatment has to be done: diagnostic, mounting, wax up, cast partial designs, referral to other specialties. So we usually do this a lot. We refer to other departments first, and our department, like I told you, comes at the last. First, the endodontic status, the periodontic status basically has to be fine. If there is extraction needed, healing has to be perfectly done before patient comes to the department. Okay, and patient education should be done. This is phase one. So coming to the phase two, then in phase two you can come to the removal of caries, extraction, the perio, interventions, occlusal equilibrium, if any processes has to be given for that. Placement of temporary restoration, the temporary crowns are all phase two. Phase three, guys, is so it's like a continuation of phase two. So we do a pre-prosthetic surgery. So this is basically mouth preparation, guys. It comes under mouth preparation. Any root canal therapies, so definitive restorations, which has to be done. Then come to the RPD mouth preparation. This is the prosthetic. This is the pre-prosthetic. RPD mouth preparation means the prosthetic part of the mouth preparation, guys. Okay. Final impression, metal trine, records if required. Phase five is like all everything done. So if in short, phase three we have done all the prosthodontic treatment after the other departments, and phase five we'll deliver the RPD, give instructions to the patient. Phase five is the periodic recall, reinforcement of education. Okay, guys. So this is basically how you develop treatment plan, and how you diagnose a case, and how you know the classification, and you know the general basics of partial denture patients. Okay, so thank you so much for patient listening, guys. Any questions, I am always there in Polyclinic 3 in the prosto department. You can come and see me anytime. um, so for reference of books for RPD, McCracken is the standard book, guys, which can be used. Okay, so you can refer to McCracken, guys. Okay, and if any other question, guys, please let me know. Yeah, thank you.